Welcome to Patients at Risk, a discussion of the dangers that patients face when physicians are replaced with non-physician practitioners. I'm Dr. Rebecca Bernard, and I am joined by my co-host and the co-author of our book, Patients at Risk, The Rise of the Nurse Practitioner and Physician Assistant in Healthcare, Dr. Naran Al-Ajba.
Good evening.
There are almost 300,000 practicing nurse practitioners in the United States. And unlike physicians who are regulated by a state board of medicine, nurse practitioners are generally licensed and regulated by their state's board of nursing, who are also responsible for monitoring the care provided by thousands of other nursing professionals in their state, including licensed practical nurses and registered nurses. Recent headlines have shown that these state boards of nursing are not always up to the task, and that this improper regulation of nurse practitioners may be harming patients. Today, our guest is Dr. Amy Townsend, a family physician and a whistleblower who reported improper care being provided by a nurse practitioner in her hometown. Dr. Townsend went through incredible lengths to get the Board of Nursing to intervene, despite evidence that the nurse practitioner was harming patients. Amy, thank you so much for joining us.
Thank you so much for having me.
Amy, I want to tell you that you are a personal hero of mine. When I heard the story of what you went through to ensure patient safety, I was just amazed. Can you share that story with our listeners?
Yes, absolutely. So, my story with this begins in back in 2017, in January of 2017. I had a very close friend of mine who had a history of very run of the mill, simple hypothyroidism. Had been on a standard dose of Synthroid for several years. But at the time was not established with a primary care physician. And my friend asked me if he thought that it would be okay if he went to a nurse practitioner run clinic, just to have his routine thyroid labs checked and to have his Synthroid refilled. A little bit of background about me. I am a board certified family practice physician. I worked shortly as an outpatient physician for a brief period, shortly out of residency, but then went into hospital medicine and have been practicing in hospital medicine for several years. Anyway, my friend asked if it was appropriate for him to go to this nurse practitioner run clinic just to have routine lab work done. My experience with nurse practitioners at the time had been mostly working with them on an inpatient basis. And I had had very good experiences working with nurse practitioners in the hospital. They helped me see patients. I saw every patient that they saw. We worked together very well as a team. They were very bright individuals. And so, at that point, I'd had a really good experience with nurse practitioners. And so I thought that it was completely appropriate to do, run of the mill thyroid tests and have thyroid replacement medications refilled by this nurse practitioner. Well, my friend proceeded to call and make an appointment with this clinic. And even prior to being seen, the nurse practitioner ordered a whole slew of lab work, what turned out to be 63 different lab tests before ever seeing the patient. These lab tests included things like a C peptide, insulin levels, DHEAS, a random cortisol levels, growth hormone. And so ultimately, after the lab work was done, several days later, my friend goes to the clinic and sees the nurse practitioner. In that lab, they had also run testosterone levels, and his level was most certainly within the normal range for a man in his 40s. It was actually the level was 696, so almost 700 for a testosterone level. And then the thyroid functions were also completely within the normal range. After seeing the nurse practitioner and them going over the labs, my friend left the clinic with a prescription for IM injections of testosterone and his thyroid medication, the Synthroid he had been on for years and years. The nurse practitioner replaced with a very high dose of Nature Throid. which includes both T3 and T4, and is not routinely recommended by the Endocrine Society for hormone replacement. And so, he brought me before, actually getting the medications refilled. He brought me the lab work and asked my opinion, to look over the labs that were there and to see if the prescriptions were appropriate. Of course, they weren't. With the nearly 700 testosterone, starting intramuscular injections of testosterone was completely inappropriate. And I was very upset with the treatment. Testosterone and thyroid hormones are not benign medications. They do come with very significant risks of cardiovascular disease, risk of stroke, risk of things like polycythemia, that were never discussed with the patient. And so I actually called this nurse practitioner and tried to discuss with him what his treatment plan, and I was very disappointed in his response. At this point I had been practicing medicine for 10 years, and was at that point was also the vice president of medical affairs for a regional hospital system. So clinically I was working as a hospitalist, but also had relatively extensive background in hospital administration as well. And his response was almost overwhelming to me, that he as a nurse practitioner, he essentially claimed that I did not know what I was talking about, and that I just didn't understand hormone replacement.
Wow. So basically, he was totally condescending to you when you reached out to him with your concerns. You knew that this was inappropriate treatment, that it could harm your friend. And his response was, well, you just don't know what you're talking about.
Yes. And
Now,
so
mhm.
I next asked, of course, in the state of Texas, every non-physician is required to have a supervising physician. So I asked for the name of his supervising physician. And then, to my surprise, when I actually contacted her, she was not an endocrinologist, not even a family medicine physician, but she was a general surgeon that was actually located 140 miles away from this clinic.
So pretty hard to actually be performing supervision when you're not in the same specialty and you're not in the same locality.
Yes, yes. And so, I after speaking with her, I expressed my disappointment and essentially told her, either you can withdraw that supervision, or I was going to consider reporting her to the Texas Medical Board for not properly supervising what was going on in the clinic.
I want to tell you, I want to stop for a second because I'm really proud of you because like I have a situation right now where I'm really concerned about a physician in my community, a specialist, just letting his PA see patients. And I realize that I need to have a direct conversation with him. And I'm not excited about it. I mean, that must have been really hard for you to call up another physician and actually just kind of call her out on what she was doing. I mean, do you have any advice for how how I can do that or the rest of us can do that?
I think what partially was the driving factor for me is this was a physician that was not even part of our community, that really had no investment in the community itself, and really had no concerns about the consequences of what was going on, and who was being harmed in my community.
I think this is something that I personally I want to learn from you and get that bravery. And I think we all need to speak out when we see things like this because otherwise it's just going to continue. So you basically let that supervising physician know that you were going to be intervening if she didn't do something. And so what happened next?
So she withdrew her supervision that same day. She retracted her prescriptive authority agreement that day, and I thought, well, great. At least we've kind of put a stop to this. But unfortunately, within a week or two, they were able to find yet another supervising physician. The
Amy,
second, the
Amy,
second, yeah.
can I just ask you on the phone, was this, did the surgeon have any explanation? Did she, uh,
Yes, so this
what
is
did
one
she
of one of
say?
her one of her comments that I think rubbed me the wrong way the most was she essentially said that she really had no responsibility for what the nurse practitioner was actually doing in that clinic. I mean, she did not feel any obligation to be controlling, what they were doing, or really providing any supervision of the prescriptions that were coming out of the clinic.
Wow. Wow. That's to me amazing.
And this is the kind of thing that nurse practitioners sometimes complain about, that they're paying them for collaboration or supervision and they're just nowhere to be seen. They're just cashing a check. I think in this case, the nurse practitioner was okay with minimal supervision because they really weren't looking for a lot of advice from a doctor. And
But
anyways,
so is the doctor. And that's something that we do need to talk about, and we do need to point out.
absolutely. And that's why Amy calling that physician out, it was so inspiring to me, and something
Amazing.
that we really need to be doing.
Yeah.
Absolutely.
And, well, much to my dismay, I thought, well, okay, this is going to solve the problem. But again, I mean, they were able to find, within a week or so, they were able to find another supervising physician. Again, this was not a physician within our community. This was an obstetrician, an OBGYN, who was over 200 miles away from the clinic this time. So there wasn't much of a barrier there for proper supervision, or even trying to stop practices that were obviously dangerous to the community.
So here you are, you already have red flags. You are really concerned about this. And then the next thing that happens is you hear about a bad outcome for a completely different patient.
Right. So all of that transpired in January of 2017, and then in February towards the end of February of 2017, and I had kind of let it go at this point. I thought that I had mostly kind of addressed the problem. But in February of 2017, I actually learned that a gentleman in his 40s had actually passed away, and was being seen at the clinic. And then having a conversation, in doctors' dining within the hospital and within, our medical colleagues, actually learned of not just the one, but a second death. So Brad Gilbo at 47 passed away on February 23rd. And then on February 25th, another gentleman named Jeffrey Childs, at the age of 44, also passed away. And so at this point, there was discussion that both of these gentlemen had been seen at this same clinic, and the kind of circumstances around their death really pointed towards issues with testosterone overdose. And so at that point, I did not feel like it was something that I could sit back and do nothing. So that was the point that I decided to actually file a true complaint with the nursing board, and send in a formal complaint, not only with the details of my friend's situation where the prescription for testosterone was completely inappropriate, but then also told them of these two deaths of these gentlemen, both again in their mid 40s, that had died and were being seen at this clinic.
So you made a formal report. In Texas, nurse practitioners are supervised by the Board of Nursing, as they are in most states. And did you get any response from the Board of Nursing about your concerns?
So, initially I got the standard response. They received the complaint and that they were going to, investigate things. Again, in my position, though, working as a hospitalist, and also in hospital administration, I began to hear about additional adverse events. They weren't necessarily deaths, but additional adverse events that were showing up in the emergency room that were patients that were also connected to this clinic. And so on, I would say, nearly a monthly, or at least every couple of weeks, I was reaching out to the nursing board, trying to get them to understand how severe the situation was, and that there were patients that were actively still being harmed, because they had not taken action yet.
Right. So like two patients have already died that you know of, that you're concerned about, and you're scared, like, hey, how many more people have to die before something's going to happen? So you actually drove to the capital of Texas, to Austin. How many miles is that from where you live?
So it's about a 5 hour drive from where
Wow.
I'm located at.
So
So, but
you were getting the runaround so much that you just had enough. You
yes,
got in your car, you drove 5 hours from your town to Austin, Texas. And did you have an appointment or you just showed up? What happened?
I had actually called ahead of time and set up an appointment with the executive director and the investigators at that point. But even prior to that happening, so the local news stations had caught wind of this clinic. They had several people that had had adverse events and had gone to a local law firm and had filed, complaints with this law firm. And the local news station got involved. The nurse practitioners that were working at the clinic had heard that there was going to be a story on the local news. So they actually went to the competing news station and provided them with a letter from the nursing board. And it looked very formal, that basically said, yes, complaints had been lodged against them, but no wrongdoing had been found. Well, it turns out that they had actually altered that document, that they added the sentence that said no wrongdoing had been found. And the nursing board at that point had, discovered that he had presented this to the public as a nursing board document. And so the nursing board finally took action and filed formal charges and cited not only the 3 cases that I had presented them with, but another 10 cases that had been filed 6 months before I'd actually filed my complaints. So there were 13 cases of mismanagement, that the nursing board did not take action until he, not because these cases were there, but because he had presented a falsified document from the nursing board.
Wow. And it actually ended up taking something like, wasn't it about a year from where
Yes.
this case was first reported to the Board of Nursing before they actually finally made formal charges?
Yes. So after they made the formal charges is when I decided, I just couldn't understand how could you cite that there were 2 deaths that were involved with this clinic, and even though they had filed these charges and made these complaints, they did not prevent the nurse practitioners from continuing to practice. The clinic was still going in full force. There were still people that I was hearing about, showing up in the ER with adverse events. So that's when I decided to go down to the nursing board and have, a direct conversation with them. And this is probably the most shocking thing, of this whole situation. So as I'm talking to the nursing board and the executive director, I said, I just don't understand. I don't understand how you can say that they are at least partially responsible for these 2 deaths, and yet you're still allowing them to practice. And they looked at me dead in the eyes and said, Dr. Townsend, doctors are just busy. And we have not been able to find an expert witness to actually review the cases and move this forward. And I just sat there in complete shock. How can a regulatory board not have the basic steps in place to actually remove people when they are harming the community? That's just something that is completely unacceptable and something that really opened my eyes to the entire situation.
Well, you said something that I quoted you in the book because I thought this was such a brilliant statement. You said, the Texas Board of Nursing seems incapable of dealing with nurses practicing medicine. They don't have a basic foolproof process to deal with nurse practitioners who are dangerous. And I think that what you describe is exactly right. This is a person that had already been sanctioned or had been charged with harming patients, and yet he continued to practice what I would consider as nursing, what I would consider as medicine. They call it advanced nursing, but it's really prescribing very high risk and dangerous medications. And no one was stopping him from doing this. And patients didn't know better, and patients were being harmed.
And actually, I would go even further. He was not only practicing medicine, he was practicing endocrinology. So
Yes.
So my dad was an endocrinologist. So this always kind of gets to me because it's one of those specialties where you do a lot of retesting. I still remember my dad saying, "Oh, well, that TSH is off." With labs, we're taught in endocrine, we double check that one lab again or whatever it is, and it's a careful specialty, and you're deliberate in your decision making. And what I find fascinating is you have a nurse practitioner, and I don't know if he was a family nurse
He
practitioner
was.
or not.
Yes.
Okay, so you have a family nurse practitioner practicing endocrinology. And to
Well,
be honest with you, what I also, with the second half of this is we had endocrinologists and family physicians who were using growth hormone for sort of feelings of vitality and some of that, prescribing it to patients. Not a single patient was harmed. And those physicians in Washington state lost their licenses
mhm.
with no
Wow.
patient harm.
That's some of the hypocrisy
Yeah.
that
And
we
so
see.
that is some of the hypocrisy in all this. Here you've got a board of medicine that's saying, wow, that's outside of the scope of your practice in medicine. So we're going to just take your license and you're going to need to go to classes and have this sort of stepwise thing. And the thing is, we've got someone who's not trained doing now endocrinology, and actually people are dying and we're not
Right.
doing anything.
And they're not only not trained, but they advertise themselves as hormone specialists. There are actually documented, photos from their Facebook page that they advertise themselves as hormone specialists.
And meanwhile,
Is
this is a nurse prac-
which is endocrinology. That's
Right.
what kind of
Right.
kills
And
me.
and meanwhile, this is a nurse practitioner who not only is family, but also he attended online nurse practitioner training. And
Yes.
he was, I think, maybe a year or so out of training when he was doing this type of prescribing. So there's a lot of red flags. And, you point out that the board of, the differences between the way the board of medicine sanctions doctors and the board of
Right.
nursing, a lot of times we hear it said, well, there are bad doctors too. And that is true. But there are definitely more interventions that are occurring more aggressively towards physicians. And I think one of the reasons is the structure of the boards. So I'll use as an example Texas, since that's the state where this happened. There are 452,000 nurses in Texas. There's 26,000 of them are nurse practitioners, 320,000 are registered nurses, and 106,000 are licensed practical nurses. On the nursing board, there are 13 people that are in charge of those 452,000 nursing professionals. But the Texas Board of Medicine has more members. They have 19 members, and they supervise 79,000 physicians, just a fraction. So how in the world can a board be expected to be responsible for this number of professionals and do a good job? And obviously they can't.
Right, right. Obviously, they can't. I mean, ultimately, I ended up finding them an endocrinologist to review these cases. It fell on me to actually provide them with a physician, an expert physician to review these cases.
Basically, you're like a good Samaritan that came in there and did this job unpaid, uncompensated, simply because you were worried about patient safety. And you're doing the job that should have been done by the Board of Nursing if they're going to allow nurses, nurse practitioners to prescribe, especially these potentially, and in this case, deadly medications.
Well, I think there's an element though that we should talk about, because this is such a great example of, the physicians who were complicit in this. And so often, when we're doing this, even in our book, we talk about, Dr. Brent Wilson and Jeffrey Reams, who were complicit in this process of hiring someone not trained to be working in a position. And so what I find so interesting is these other physicians involved that would just sign off on a clinic. They've never been there. They're not, working face to face with a non-physician, and that's not being against, in my opinion, we are not against this profession of nurse practitioner or physician assistant, but I think we owe a duty of care to patients, that if our name is going to be signed on as a supervising physician, that then we take that care seriously.
Yeah. And
So
that was
yeah.
one of the other things that was a complete eye opener to me, was that that there were physicians out there that were willing to to compromise the quality of care, and some of them are doing it just for financial benefit. And we as physicians need to continue to speak out against that and hold our own accountable.
Absolutely. But I will
Have
say
you
that
experienced any backlash at all, Amy, from kind of doing this and standing up? I mean, I'm so proud of you. I'm so impressed by your bravery.
I mean, it wasn't, I mean, I was so frustrated with the whole situation that there was no way that I was going to, back down and continue to see people in the community that were hurt. I mean, I just, it was something that wasn't even an option to quit. But as far as backlash from the physicians, no, I did not get any backlash from the physicians. I did get a lot of backlash from staff that worked at the clinic. And surprisingly, this nurse practitioner was very involved in a church, and the congregation and the church members actually gave me a lot of backlash, and very unpleasant experience, and attempts to attack my character.
well,
Oh, I'm
Noreen
sorry.
and I we talked in the book about how so many times patients don't really see the dangerous side, the safety side. They see that somebody cares about them, someone is being nice to them, trying to make them feel better. And I think in this case, Kevin Morgan wanted his patients to feel more of a sense of vitality and healthfulness. And indeed, the patients must have felt better because they followed up and they kept going back. And patients often don't know that they're being mistreated or receiving the wrong care and that it can harm them. They often just see the side of it that this is a nice person, a caring person, and you hate to be the bad guy, but patients don't have the privilege of knowing that this could potentially kill them. And unfortunately, that's where sometimes we have to be the bad guys and tell them the hard truths that they don't always want to hear. That's tough.
Yeah, absolutely.
Well, I want to just make a few points about some other states because we've talked a lot about Texas, but Texas is not the only state where this problem has happened. Recently, California Board of Nursing made headlines because in 2016, they had such a significant backlog of complaints that the system allowed a nurse who was accused of contributing to the death of a child to continue to practice for over 3 years. And just this year, the board was accused of falsifying documents to make it appear as if complaints against nurses were being investigated in a timely fashion when indeed they were not. In Tennessee, the Board of Nursing allowed a nurse practitioner to practice even after state attorneys recommended that her license be revoked. She was one of Tennessee's top opioid prescribers, accused of prescribing massive amounts of controlled substances. She defended herself to the nursing board by pleading ignorance and saying she was simply refilling prescriptions, and she just later learned that the doses were too high. And then in New York, a nurse who was attending a nurse practitioner school reported her online school to the Board of Nursing in New York for failing to follow the requirements in New York for the educational preceptorship and just the educational lessons. And she basically got nowhere, and the Board of Nursing closed the case. So I just bring these up as just some examples of the fact that boards of nursing across the country are struggling. And as we continue to allow independent practice, there are a lot of concerns about whether they're capable of actually making sure that improper nurse practitioners are not practicing and potentially harming patients.
Amy, what advice would you have for any physician who's listening to this podcast about what to do if they find themselves in a similar situation?
I think the biggest struggle for me was the feeling of being alone and not having a lot of support. Even discussing the situation with a lot of my physician colleagues in the community, they all knew that this was going on, but no one was willing, I think, to step up to the plate and actually do something about it. And we need to reach out to each other, I think, and support each other, in holding people accountable, and upholding, the medical standard of care, in each of our communities.
I think
Right?
that coming together is so important and having the solidarity. I'll point out that Amy and I are both board members of Physicians for Patient Protection. And one of the things that's so important about this group is that it does provide a place for us to talk to each other, to provide support for each other. I think, Amy, that might have been one of the ways you were able to find an endocrinologist to help testify, was through that group. So if you're a physician out there listening, I really want to encourage you to join our group officially, and you can find out more about us at our website, physiciansforpatientprotection.org. So please join us there. And we also encourage you to learn more about this important issue to get our book. It is called Patients at Risk: The Rise of the Nurse Practitioner and Physician Assistant in Healthcare. It's available in print at Barnes & Noble and in Kindle at Amazon. Thank you so much. We're going to invite Dr. Amy back to talk again with us at an upcoming podcast. Please subscribe anywhere that you listen to your podcasts, and also at our YouTube channel, Patients at Risk.